Okay, Assalamualaikum and good afternoon. Um, Today I was actually thinking of what to do, so I decided to talk about diabetes in pregnancy since I haven't done that before. So I think we'll start with the lecture. Yeah. Okay, my slides are already up. Now, the what I put up as a topic was I'm pregnant and I have diabetes. What should I do? This is a topic that this is a question I get asked all the time. Patients come in, they're worried, if they have diabetes, they cannot get pregnant, or if they're pregnant, So I hope that this will give you some idea of what we do in practice and what it means for you. I'll be happy to take questions at the end of the session. So now the problem is diabetes in Malaysia is very common. You've heard from my previous talks that, almost 20% of our population have diabetes. Therefore, when you have a significant number of the population being women and of childbearing age and all that, so it's most likely that someone's going to get pregnant either accidentally or intentionally. And this is a problem, especially if they are diabetic or they have a high risk for diabetes. So the question is, how big is the problem? Now, when you think about it, diabetes in pregnancy is associated with certain risk factors, and having diabetes in pregnancy is a risk to the woman as well as the baby. So the incidence of diabetes in pregnancy in 2011 and 12 was around about 8 plus percent. I think right now we don't have any latest figures, but it's probably higher. So if you think about it, 1 in 10 pregnancies will have somebody who has diabetes. And the problem is that, with diabetes, with all of these problems that come with diabetes, the cesarean section rates are higher, 13%. And a lot of babies that are born to diabetic mothers actually weigh more than 4 kilos. So when you have someone who has diabetes and the baby is very big sized, it tells us that the control during pregnancy was not very good. So this is something we need to actually talk about. Now, there are two situations here. One, a patient has diabetes and she gets pregnant, either, as I said before, either intentionally or accidentally. The second problem is that the diabetes is discovered during pregnancy, and this is what happens during the so called screening process. We look at patients, we decide, okay, is this patient at risk of developing diabetes? The obstetrician decides, does the patient need to get an oral glucose tolerance test? And this is what we call screening. So now the problem is, as we screen patients, we look at patients. If someone's, before pregnancy or at the very time the is in the overweight or obese category, there is a history of previous diabetes in pregnancy. There is someone in the family who has diabetes, history of big babies, more than 4 kilos, a bad obstetric history, that means unexplained death of the baby, congenital anomalies, etc. And the shoulder got stuck during delivery. These are risk factors. If you have a lot of urine glucose, this is also another thing that we look for. You know how the KKM posters have these pictures of patients and you pee and then the ants come and all that? That means that there is significant urine glucose. And of course, if there's problems like, hypertension and pregnancy induced hypertension, there's a lot of amniotic fluid, the fluid that surrounds the uterus, and if they're using a lot of steroids. So these are risk factors that we need to identify and screen patients to make sure that our patients can be, screened before they embark too far into their pregnancy, so that we don't have too many problems. How do we screen? Well, basically, it's a glucose tolerance test. Most of you who have had this done, it's not a pleasant experience. We put glucose into water. We put 75 grams of glucose, and then we make it into a certain volume, and then we make the patient drink. When the patient drinks, we check bloods 0, 30, 60 minutes, 2 hours after the drinking, and then we try and measure these glucose levels to see whether there is a problem or not. So if the fasting blood glucose is high or the random is high, more than 11.1, this is called diabetes. However, in the second trimester, we usually look for what is called a third trimester. We look for gestational diabetes. So we may at some point repeat the glucose tolerance test at weeks 24 to 28 and try and get some idea of whether the patient has any gestational diabetes or not. Now, what I want you to understand is that when someone is pregnant, when someone has a glucose test done in a normal individual, if they are called pre-diabetes, in a pregnant individual, pregnant woman, this is called gestational diabetes. So, this is something that we as doctors always look out for in people who are potentially pregnant. So, gestational diabetes basically means carbohydrate intolerance, which is first recognized during pregnancy. So, when someone is pregnant, we check there is diabetes, and that's the first time you make a diagnosis. This is gestational diabetes. And the problem with gestational diabetes is that 15% of the women actually will remain diabetic. And as I always tell my patients, every year there is about a 10%, 8 to 10% risk that you will develop diabetes. So within 10 years, there is a very strong possibility that you're going to become diabetes and diabetic. Now, GDM is diagnosed if you have a high fasting plasma glucose, a 2 hour plasma glucose that's very high. And if you have diabetes, it is suspected if you actually have the traditional numbers here. So the message is that a lower sugar level is used to make a diagnosis of diabetes in pregnancy. Why do we need to worry? Well, when someone is pregnant and they have diabetes, we worry about malformations. So there are many malformations that can occur early, especially in the first trimester. This is what you call embryogenesis. During the first few months of the baby's development, there is a high risk of development of all these complications. From 8 weeks onwards, there is other problems like enlarged organs, too much amniotic fluid lah. The baby can be too big, the baby can die in utero, etc. But the problem of malformations usually occurs in the first month or so. And the thing is that when you think about it, the birth defects, the most important toxic risk factor is sugar. So the sugar control is very, very, very important. If the diabetes occurs after the first trimester, there are no birth defects. So this is important, particularly for those of you who are diabetic, who are going into pregnancy. We want to make sure that your sugar control is very, very tightly controlled so that you don't develop these malformations, okay, or birth defects. So HbA1c is an important risk factor, and an HbA1c, which is the average sugar for the last 3 months of greater than 7%, increases the risk of birth defects. Now, what can happen to the baby after delivery? You heard what can happen before. After delivery, baby can get low sugars, they can have too much hemoglobin, become polycythemic, they become jaundiced, low calcium, they can have a weak heart or heart failure, they can have respiratory distress and birth trauma. So imagine if you are about 155 centimeters tall, 160 average height, and then your baby weighs 5 kilos or 4.5 kilos. How are you going to deliver a baby that sized without trauma? So, this is why a lot of patients who have big babies end up going for cesarean section because of the risk of trauma to the mother as well as the baby. So the effects on pregnancy as well, shoulder dystocia. Dystocia means that the shoulder gets stuck. So when you're trying to deliver the baby, you can deliver the head, but the shoulder gets stuck because the baby size is quite big. Mother can develop hypertension, preeclampsia. They can get urinary infection as well as pelvic trauma during the whole delivery process. So diabetes is not about the baby alone. It can also have impact on the mother as well. And this is why as an obstetrician sees the patient, sees the baby and all the rest of it, as physicians who look after pregnant women, we also have to make sure that we are looking after all of these aspects as well. So when you talk about management of diabetes in pregnancy, how will the doctor treat you? How will your doctor treat you? Basically, if you know you have diabetes before you get pregnant, then it's very important to plan the pregnancy. Don't come and tell me, oh, doctor, pregnant. Third pregnant is a difficult thing for all of us because it means that there is a lot that needs to be done while you are still pregnant. So usually we tell patients, look, we do pre-pregnancy counseling. We try and get the sugars down to 6.5%. We need to screen for complications of diabetes, eye problems, kidney problems, etc., before we embark on pregnancy, so that during pregnancy these things don't get worse. If we can treat, then we don't have to worry about them during pregnancy. Most of the time, we may change to insulin because we want sugar control to be tight, and insulin is safe to be given to a pregnant woman. And we may need to adjust other medications like blood pressure medication, etc., and give you something that is safe to be taken during pregnancy. So, a lot needs to be done, and we need to plan. This is why we always tell patients plan your pregnancies. This is very, very important. If when you think about it, there's a lot that needs to be done also. Oops, I go back one slide. So women, as I said before, there's a lot to be done, and this is from the clinical practice guidelines. This was supposed to actually slide in with animation. Somehow it's not working. But basically, the point is that when you plan your pregnancies, we have enough time to make sure that whatever is harmful to the baby can be removed. We can make sure your sugars are okay to reduce the risk of birth defects and so on. So the diabetes in pregnancy is different from diabetes outside pregnancy, meaning when you're non-pregnant and you have diabetes. For most patients with diabetes, the aim of treatment is to prevent complications, blindness, etc., etc. And this is done as part of the routine. You've heard me speak about this before. But during pregnancy, the goals are different. It is to prevent the baby from being too big, it's to prevent fetal death, it's to prevent other complications, and also equally important is to ensure that the mother is safe. So we need to do all this when pregnant, as opposed to someone who's diabetic, where we have to look at cardiovascular, renal, and other complications more importantly. So to you, this means that during pregnancy, you may have to visit more frequently, especially if your sugars are not controlled. We need to have strict sugar control. We need to have regular exercise. For those of you who smoke, you need to stop smoking because it's bad for the baby and for you. Now, sugar control during pregnancy is equally important. So, we always encourage mothers who are pregnant to monitor as often as they can. This means many times per day. It means that there's but specific timings your doctor will discuss with this with you. But basically, if you realize, we try and keep fasting sugar levels very, very tight, and even 1 or 2 hours after meals, this has to be almost less than 7.8 at 1 hour. The reason is that if you have high levels of sugar after you eat, irrespective of whether you're type 1 or whether you're gestational diabetes or whatever it is like you're giving your baby too much food, because glucose can cross over in the placenta. So when you give too much glucose to the baby size grows and it's like overfeeding. And this is what one of the factors that leads to a large baby during pregnancy. Weight gain. If you're underweight, you're allowed to gain a certain amount of weight. If you're obese before you start the delivery or the pregnancy process, then your weight gain has to be minimal, because the more you gain, the more problems you're going to have, especially if you're starting either overweight or obese. So, this is how we guide patients and tell them, look, your weight needs to be restricted. And especially towards term, our last trimester, we need to really keep that in check to prevent complications for the baby. So the diet is important, and the main thing is that you need to provide adequate calories and nutrition to sustain pregnancy, but you need to choose your foods wisely so that your sugars don't go up. And this is why monitoring is important. You know, this whole concept of oh, saya berhamil, saya kena makan untuk 2 orang, I have to eat for 2 people. That's not quite true, because you have enough reserves for your baby. So you need to maintain a certain glucose level to ensure that your diabetes is under control. So usually what happens is patients will either see a dietitian or a diabetes nurse educator to be educated. But the only way to really achieve this is high motivation and frequent monitoring, because if you monitor, then you know what's good for you and what's bad for you. Exercise, again, we tell patients, look, as long as you don't have any major issues, if you're diabetic and your diabetes is well controlled, you should be able to perform exercises, brisk walking, swimming, low impact aerobics, and so on. Yoga and Pilates good for stretching and for the back pain as well, and strength training. So you are actually, this is from our Malaysian clinical practice guidelines. So you can actually exercise safely during pregnancy. If you're worried, get your doctor to advise you accordingly. Now, when your sugars are not well controlled, usually we see the patient once and we decide, okay, within a week or two, we need to start medication because the longer you wait, obviously there are more problems. So we don't waste time. So if your sugars are not well controlled, metformin can be used as a first line treatment. Metformin is used for diabetes and pre-diabetes, and it is safe to use during pregnancy. So you do not have to worry. And if you're ready on metformin, as we because of the pre-planning, preconception planning, etc., then you can actually safely continue your medication. Again, we encourage patients to monitor as frequently as possible. So metformin is safe. It's been studied to a maximum of 2000 milligrams, which is what we normally use. It does not cause hypoglycemia, low glucose in the baby or for you. So it is safe to use in pregnancy. What about insulin? Now, insulin again is safe to use in pregnancy. A lot of pregnant women are reluctant to start insulin because they say, "Oh, saya dengar dari ini daripada babi lah, dari khinzir lah, animal porcine." Nowadays, we do not use animal insulins in most countries. We use what you can see here is a pen device. We use pens to deliver. We don't use syringes anymore most of the time. So it's easy to deliver. I've got 3-year-old children who inject themselves regularly. There is no reason why a healthy adult should not be able to inject safely. It will not penetrate your skin and go and harm your baby. All of that is actually uncalled beliefs that people, misconceptions that people have. So insulin is safe to use. Your doctor will decide on how many times you need to inject and so on. But generally speaking, the message I'm trying to tell you is that sometimes tablets don't work and we need to use insulin. So do not, when you see a doctor, when you see me, you see your obstetrician, do not expect miracles. You have to work with us. So there must always be a combination of medicine. We have to diet, we encourage you to exercise. And sometimes you will realize that if we start medicine, we do not get immediate control. It takes time. So we need to adjust your medications and so on, especially if this is insulin. So it takes a few weeks to get to control, but eventually you will get to control. And at the same time, the obstetrician will be monitoring the health, the well-being of your baby. And sometimes you have to realize that exercise actually makes things better. So if you're walking even 10, 15, 20 minutes a day, this will help reduce your glucose levels. And if your sugar levels are very high, oral agents, metformin alone will not work. You need to combine it with insulin. There's something called fetal surveillance, and I'm not going to go through this in detail, but what I'm trying to tell you is that every step of your pregnancy, your obstetrician will monitor the progress of your baby. And this is important because then you feel reassured that what you are doing is correct. As a physician, I'm treating your diabetes. I'm reassured that I'm actually treating your diabetes properly because your baby size hasn't suddenly increased, as could happen if your sugar controls are not good. So, this is reassuring for all of us. Delivery, there are various guidelines, but basically, most of the time, if you're uncomplicated, most Caesars or deliveries are planned around 37, 38 weeks, sometimes earlier. Sometimes we need to give if we're anticipating an even earlier delivery, maybe by cesarean, around 37 weeks, your obstetrician may give you steroids to mature your baby's lungs, and this can also cause the sugars to go up. So, this is decided by your obstetrician. And really, if your sugars are on the high side because of steroids, we need to adjust your medications. After you deliver, breastfeeding is encouraged. You can safely breastfeed even though you're on metformin. We check again after 6 weeks to make sure that you haven't gone into full diabetes. And if you're non-diabetic, your glucose tolerance test is okay, we can consider taking metformin. The reason being that being having diabetes in pregnancy is a very, 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 very big risk factor for developing diabetes in future life. So we try and encourage you to continue your lifestyle changes. I always tell my patients breastfeeding is like an Olympic sport. You burn a lot of calories, and this is good because it actually helps you prevent the diabetes. And most importantly, you have to realize that a lot of gestational diabetic patients will develop full blown diabetes within a certain number of times. So you need to actually screen regularly and not just say, oh, I forget about it and I'll worry about this later. It is a real problem. If you were diabetic before pregnancy, then you may need to stay on insulin for a while, especially if you're breastfeeding and you were on a lot of medications before, because we try and minimize the number of medications we give you during this breastfeeding period. The dose of insulin may come down, but all more, and especially now, you still need to continue monitoring and so on to ensure that your sugar levels remain healthy and so that you can remain fit and look after your baby. So, with that, I would like to thank you. So, what I've done is basically I've given you an idea of what we need to do if you're pregnant, if you have diabetes. If you're diabetic going into pregnancy, it's fine. Plan your pregnancies. If you develop diabetes during pregnancy, it's also fine. But in essence, you have to be motivated and you have to be encouraged to actually continue your care because it is important for the well-being of your baby as well as yourself. Thank you. I'll take questions if there are any questions. Doctor, can I consume diabetic medicines during pregnancy? Okay, as I mentioned during the talk, the only medication that we use actually, which is allowed in Malaysia for the pregnancy is actually metformin. Metformin is known as glucophage as well, and this is safe to be used in pregnancy. All other diabetic medicines, oral diabetic medicines, cannot be taken. Insulin is safe to be taken. Lagi, it's hanging, is it? Okay, hang on. The internet is slow. Bahagian badan yang mana yang boleh terjejas disebabkan oleh penyakit diabetes? Okay, so penyakit diabetes, kalau anda tidak maksudkan sewaktu tidak hamil lah, tidak pregnant, then diabetes yang tinggi dan tidak terkawal akan menyebabkan kerosakan mata, kerosakan buah pinggang, jantung dan sebagainya. Tapi ini jangan anda panik sekarang lah, sebab benda ini akan berlaku setelah 10 tahun anda mempunyai diabetes yang tidak terkawal. So pada awalnya anda harus menjaga diabetes supaya tahap HbA1c itu di bawah 7% untuk mengelak daripada komplikasi. Kalau waktu pregnant, bahagian mana yang boleh terjejas? Well, kadar kerosakan mata juga boleh meningkat sewaktu anda hamil. Jadi sebab itu sebelum pregnant kita harus periksa kidney, buah pinggang, periksa mata dan sebagainya untuk memastikan bahawa faktor-faktor pertumbuhan yang dihasilkan oleh baby anda tidak akan merosakkan mata atau bahagian yang lain. So saya harap anda sudah mencukupi untuk soalan ini. I'm craving for something sweet. Can I eat it? Does it affect my diabetes? Well, anything sweet that is consumed will affect your sugar levels for sure. So now the question is that we always tell patients, look, when you're craving something sweet, once in a while it's okay to indulge. It's okay to have a cheat day, but you cannot crave something sweet all the time. So if you're craving, so for example, some chocolate, you don't take a chocolate that's full cream chocolate lah. Basically, you go for a dark chocolate. So a dark chocolate is still chocolate. It may not be as tasty, but it will still satisfy some of your cravings. If you're going to if you're going to eat fruits, for example, you can take a piece or two of an apple or something like that, but don't overdo it. It will affect your diabetes if you overdo it. Okay, our internet's a bit slow today. Adakah penyakit ini boleh turun kepada bayi di dalam kandungan? No. Ini bukanlah sesuatu yang penularan atau vertical transmission seperti infection. Jika anda mempunyai katalah hepatitis B dan sebagainya, ya itu boleh, infection itu boleh turun kepada baby. Tapi diabetes tidak, kerana diabetes ini biasanya adalah sesuatu yang berlaku kerana mak sendiri ada faktor risiko. Faktor risiko seperti obesity, seperti apa tadi, riwayat diabetes dalam kandungan sebelumnya dan sebagainya seperti yang saya ceritakan tadi. So ini bukanlah penularan atau direct transmission kepada baby, tidak. Apakah tanda ibu hamil mengidap diabetes? Okey, biasanya susah untuk bedakan gejala diabetes dan gejala hamil. Kerana seperti mana yang anda yang pernah hamil tahu, anda akan rasa letih, mungkin sering pergi ke toilet, malam-malam terpaksa bangun untuk pergi ke toilet dan sebagainya. So semua ini adalah gejala diabetes. So kalau gejala diabetes dan juga gejala seseorang yang hamil. So biasanya kalau anda khawatir atau doktor anda khawatir seperti yang saya bicarakan tadi, cakapkan tadi, then kita perlu screen seseorang itu untuk melihat sama ada beliau ada diabetes atau tidak. Glukometer yang ada alat periksa gula itu, glukometer, mudah dicari. Setiap orang setiap rumah ada satu alat itu. Jadi anda boleh cek. Jadi kalau anda khawatir boleh pergi ke farmasi atau apa, mereka boleh cek. Tetapi biasanya kalau seseorang yang pregnant ada faktor-faktor risiko, anda akan di-screen. Now, di kebanyakan tempat di barat, mereka melakukan universal screening. So, saat anda tahu anda hamil, mereka akan periksa untuk diabetes. Di Malaysia itu digalakkan, tapi kadang-kadang ini tidak berlaku. Jadi kalau anda khawatir atau risau, then minta untuk untuk disaring untuk diabetes. Boleh saya tahu apa kesan kepada baby jika ibu mengidap diabetes semasa mengandung? Okey, so semasa mengandung seperti yang saya tunjuk slide tadi, biasanya apa yang kita khawatirkan adalah pertama sekali bila diabetes itu berlaku. Kalau diabetes berlaku pada stage awal, maksudnya trimester pertama, then risiko adalah um, apa yang kita panggil kecacatan kepada baby. Maksud dia ada kecacatan di jantung, dari saraf dan sebagainya. Tetapi kalau gula itu diabetes berlaku dalam trimester kedua atau ketiga, dan kesan yang akan berlaku kepada baby adalah saiz baby akan besar. Um, Mungkin setelah baby lahir susah untuk dilahirkan, risiko untuk jaundice, untuk kuning setelah lahirkan. So kita harus tahu bila diabetes itu berlaku, sama ada diabetes itu tinggi atau tidak pada trimester pertama atau tidak, atau trimester ketiga, sebab apa yang kita panggil gestational diabetes. So dari situ kita boleh tahu apa kesan kepada baby. Tapi yang penting adalah walaupun trimester pertama, kedua ataupun ketiga, kita harus pastikan tahap gula puan itu dalam tahap yang kita mahu, yang direkomend oleh pihak Kementerian Kesihatan dan sebagainya untuk mengelak complication kepada baby. Okay, tak ada soalan yang lain. Okay, terima kasih. Thank you very much. I look forward to doing another session with you sometime next week. Look out for that advertorial. Thank you.